Welcome to the Low Carb MD Podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor. We're going to try it. All right, guys, welcome to the Low Carb MD Podcast. We really have a special guest today. It's Dr. Ali Ibrahim. He's kind of like a dark horse, kind of somebody who leads from behind. He's not on social media, but he's a big proponent of lifestyle measures, particularly low carb diets, and their utility. He recently ran, besides being a physician, a consultant, child and adolescent eating disorder psychiatrist, he just recently ran 100 miles completely fasted. Did I get that right? Completely fasted?
Yeah, that's right. It was completely fasted. I mean, in all fairness, we did it as a group, so that really made it a lot easier. It wasn't me on my own. It was a group of 8 of us, 2 type 1 diabetics, and it was Ian Lake that was leading on the project. And hopefully we're going to be writing a lot more about that soon. But yeah, no, it was entirely fasted for the 5 days. We started off, the thing is that when it started off, it to me looks like a little bit of a challenge. I mean, I didn't know where it was going to go, but doing the thing itself, now looking back, and even at the time, it really wasn't a challenge. It was just kind of, stretching what is, normal human physiology to just, a different limit. And I'm pleased that we did it. I'm pleased that we did it because the primary objective of that project was proving that nutritional ketosis is okay in type 1 diabetes. And I don't think we needed to go that far to prove it, but I guess now that we've done it, it illustrates something. And I guess there's something as well to be said about, the not just the safety, but the normality of what I don't like to refer to as intermittent fasting, but more so periodic eating. It's normal. It's not something that anybody's advocating. It's just normal human biology. And it seems to be at the moment something that people are very touchy about. But if you don't want to do it, you don't have to do it. But I think it's the opposite that's creating the problem. It's promoting regular eating several times a day that doesn't seem for me to be fitting with kind of normal human biology, but actually it's creating the problem. And that's where my specialty is. It's eating disorders. I'm seeing more and more kind of issues and people coming to my service, particularly children, which is heartbreaking. I mean, my subspecialty is children with eating disorders, and it is really hurtful to see the amount of children that are presenting with this problem. And actually, what we're doing is promoting exactly that. The one thing that I think might have created the problem in the first place has been advocated by services, which is regular eating, and actually what we're giving them to you, which is highly processed food. So back to the idea of kind of fasting and this event being done fasted. I think yes, absolutely, stretching it to the kind of lengths that we did is just to prove a point, because it's it's a finely controlled study, and that's different. But I guess it shows that there's something to be said about eating in a way that's compatible with normal human biology, but the way that we're made evolutionarily.
Brian, I don't know how you the longest I've gone fasted, I think, well, besides my let's escape my childhood eating issues, right? Okay, but maybe it's 3 days. Can you imagine going, what was it, 5 days and 100 miles? Can you imagine that, Brian?
Yeah, but sure. The thing is that before that event, I actually didn't. I hadn't gone beyond just below 48 hours. It wasn't something that I'd contemplated before. It wasn't something that I'd probably do again, and I didn't think that I'd be able to do more than 48 hours. I mean, just for the record, it's not something that that I thought I'd be able to do. I actually went there and I thought, I'm going to let these guys down. 2 days in, I'm going to stop, because I have. So when I tried it, everybody else kind of gave it a go, and experimentally just gave it a little bit of bash before we started, and I got to do days and I had to have a piece of steak. I couldn't last more than 2 days. And in fairness, in that time, I wasn't actually moving. I wasn't exercising the way I'd normally do. So there was maybe something about that. But when we started the actual thing, it wasn't as though I was, massively prepared for it or anticipating being able to complete it. But it felt seamless. I mean, it must be said, it felt seamless at the time. And I think the thing that helped, I think, and this is me hypothesizing wildly, but the thing that I think that helped is that actually moving during the day. So the mileage, even though I thought would be the challenge, was actually the thing that made it easier.
Yeah, I think that's true. I just did an extended fast for the first time, like 12 days with the head of the school that I'm at. And, it was we had a really good time, and it was amazing how we didn't have hunger, but we weren't obviously exerting to the degree that you were. So you think that and were you, I didn't see if you were following ketones and all that kind of stuff during this whole process when you were fasted and working out to a high level. If that has something to do with your satiety and not being hungry or just being distracted by the exercise.
Was that being low carb, you mean, or?
Yeah, you were fasting during these 5 days and putting in 100 miles, right? With the amount of activity that you were having. Were you following ketones to see what they look like during this whole process?
Oh, ketones. Yeah. I mean, that's exactly the point. Yeah, exactly. So,
I think they had CGMs on, right? Ali, you had CGMs,
yeah, we had
right?
CGM.
Were you wearing a CGM and you guys were tracking all this stuff, right? Pretty closely.
Yeah, exactly. So, we were tracking all the various parameters, I had CGMs on. I mean, in fairness, mine kind of went on and off for technical issues kind of over the days, but it really didn't matter because actually I was running a flat line throughout. And it was pretty low in terms of glucose monitoring, but ketones, yeah, Brian, you're absolutely right. I mean, I started off with high ketones, it increased over the days, and that's got to have done something. But the interesting thing is that if you look back to the way I kind of wrote about it and blogged it, because all the blogs that I wrote were kind of on that day. So in the evening, I'd go back and write about how I felt. And it's in line with what was happening to the ketones, which is really, really interesting. Over the days I was feeling increasingly energetic, increasingly clear in my head. I was feeling and there was a point where halfway through, and I'm sure it was on day 3, if I remember correctly, I was kind of verging on hypomania.
And wow. Did your ketones change with the exercise? Did you see like pre and post? Because I was curious when I was doing my fast, my ketones usually run 0.4, 0.8, something like that. I was like 4.4. I got up to 5.8 after a long hike, but then I did a big weight workout and my ketones dropped in half, like very quickly right after the workout. And I was and my sugar stayed totally flat, like 78, 82. And then my ketones went from 4.4 to 2.2 after working out. So I was curious if you saw changes like that or if you saw
it's curious that you say that, isn't it? Because that's exactly what was happening. I mean, I started off on day 1 with an interestingly high kind of ketone number. Not that the numbers matter, but I started off at 2. And I think that was probably because of what I'd had the day before. So really high fat meal, anticipating 5 days of being fasted. Probably didn't need to have that much. I think I overdid it. But yeah, absolutely. After each one, I'd do ketone levels after we'd come back from the run, and it was definitely lower than it was in the morning.
I have a question. So how do you go from how do you get here, right? So you did 100 miles, fasted for 5 days. How do you get here? You're like, you didn't dream about this as being a young, probably college student or young student, like I'm going to grow up to be a doctor. Your parents are happy, they're like, Ali's going to grow up to be a doctor. How do you go from I'm interested in medicine to I'm going to run 100 miles completely fasted because I got to show the world something? And I'm very familiar with your 2 most recent research articles, and we'll post those on the show notes so people can read them. They may have read at least one of them when Agnes came on. But Can you talk about how this happened? You know, how you ended up becoming a psychiatrist, how you ended up focusing on eating disorders, and then how do you get here? You know, how do you get here? I just want to know the person, you know? I kind of want to understand the person.
Yeah, such an interesting question. The reality is that, you know, it comes from a place of not just passion, which I would like to say is just passion, but it's a little bit of frustration and a little bit of anger. And you know, I was, as you say, I went to medical school to you know, to, I guess, with the dreams that we all had, you know, going into medical school. And then I realized very quickly that, you know, things were kind of, you know, standard in the approach, and it wasn't, you know, we weren't kind of coming up with creative, bespoke, you know, plans for individuals in a way that I had in my head before going into medical school. The thing that I found, you know, more so frustrating and then be angry that I talk about is when, I started a specialty that I was never exposed to when I was at medical school, and that was, you know, for me, it was the first time I'd come across eating disorder. I was very fascinated by it, and it was, at first I was drawn into it, and I thought, you know, this is something that's really interesting, and I did choose it as a subspecialty, and in my junior doctor training years, I went through several kind of rotations doing eating disorders in different settings, so inpatient, outpatient, community stuff. And this is no criticism of Agnes, but when I worked with Agnes, that was when I went from having my first encounter on an inpatient ward, seeing my first, you know, patient with an eating disorder, thinking this is definitely my chosen subspecialty, I'm interested in this, to then working with Agnes on the ward and thinking, you know, sod this, I'm not doing it because, you know, things are so corrupt that I'm not going to be a part of this. And it was actually Agnes's approach that made me think, you know what, there's somebody here that, you know, can think a little bit differently, a little bit laterally, and can, you know, I have a duty and an obligation to, you know, change what I can see is kind of, quite frankly, medical negligence and malpractice. And the thing that would surprise me was that, you know, where it's the discrepancy between, you know, it's completely contradictory, isn't it? You're working in an eating disorder unit where the main problem is eating, and they're not looking at the specifics of what patients are being fed. You know, everybody's getting the same thing, and it's all standardized, it's all ultra processed, and that includes people that have comorbid issues where actually it doesn't make sense to give them the same type of food, like diabetics. Now, interestingly, at that time, I raised that question with the team, and I had a dietitian criticizing me for saying, you know, how, you know, we've got this, you know,
how dare you restrict their food? How dare you restrict their food, right? I'm sure they said, they pointed the finger, do not restrict it, you know, because we get that criticism all the time.
Yeah, exactly. And it was like, you know, we've got this doctor who's promoting eating disorders, working in an eating disorder unit. And it's like, well, actually, the patient's disordered because of the fact that you're pushing carbohydrates on them. And they're saying, I mean, you know, I had this patient in her early 20s, you know, in a very sophisticated, eloquent way, telling me, look, you know, explaining to me the exact mechanism. By that point, I hadn't actually come across low carb. I didn't know about low carbohydrate treatments and how they're, you know, relevant to diabetes, let alone other diseases. It was, for me, it wasn't something that was on my radar. But it was me sat down with a patient, listening to her, expressing her frustration, explaining that actually, if I didn't have to, as a type 1 diabetic, titrate and get this conflicting advice from different professionals, from eating disorder professionals, from diabetologists telling me how to manage my diabetes, I probably would, you know, can I give this a go? And I said, well, that sounds reasonable. And that was frowned upon. And I mean, I was just completely, you know, thrown back by, why on earth is that frowned upon? I mean, it's, you know, surely that's exactly what we should be doing.
Can I tell you my theory? Can I tell you my theory why? Because I think it's important. I mean, yes, we're going to have Belinda Fedke, but we had Gary Fedke talk about the interest and the religious component that's infiltrated a lot of nutrition and modern dietetics in the United States, at least. You know, Kellogg's and the Adventist Church, you know, have had a strong influence. There's one component, but I think there's a whole nother component that you tell me if I'm wrong. I looked into the literature. I said to myself, why are the dietitians so interested in promoting a non-restrictive approach to healing, right? Why is it why do they Why do they want that? And if you look, I looked at the statistics. They're among dietitians and nutritionists, they're 5 times more likely to have suffered from anorexia than a conventional person.
You know
right?
what? I know from first-hand experience of working with different professionals, both in eating disorders and certainly in the UK. I don't know what's happening in the States, but I would say that's a gross underestimate.
Yeah, and so if you look at it, and I agree with you, this is just
But
self-reported. This is the things that they report, right? So yes, I agree with you
exactly.
that it's probably much higher. We know it's higher. So now, if you're dealing with people who are convinced that non-restrictive eating is the way because maybe they've had some thin idealization, or maybe they've had what's that term? Like they've had this weird concepts of what health is, right?
Sure.
And so they, for themselves, believe they need to eat in an unrestricted way because they have like this very bizarre kind of limited
well, they can
appetite.
things being over, and the thing that is commonly followed is if you're able to include anything in your diet, regardless of what that is, then not be quote unquote triggered by it, then that kind of speaks to you being normal and not being disordered, and that in itself, that's where therein lies the problem. Because if we look at the figures and we know that 75% of most food that's available to us is processed, then if we're saying that anything that we have to be okay with including anything into our diet for it to be for us to be normal, then that predicates that you're having to include things which aren't compatible or proven to be safe for human consumption.
Yeah. I mean, I think this is a problem. I think they're cut from a different cloth than most obese, diabetic, and so their view is you cannot restrict. But then you get these binge eaters or even bulimic patients or people who've had bulimia and they have these incredible compulsions. It's like a different, it's kind of like two sides of the same coin, but they don't understand each other. I had a nutritionist come to me and tell me, Tro, I don't believe in restrictive eating. She's thin. She's got essentially 4% body fat or 5% body fat. She exercises every day. She's probably, and she has no appetite. And she tells me, I can just cut my portions to about half the size that I think is, normal. And that's her approach to maintaining her health. Right. So she's like, I don't believe in restrictive eating. And I think dietitians have that issue. They're cut from that cloth. They don't understand people who will compulsively, they don't understand food addiction. They don't understand obesity. They don't understand how restricting foods that are, that affect our neurochemistry and biochemistry, how that could be a salvation. And finally, I said to her, would you ever tell an alcoholic to keep drinking or drink in moderation? No, you wouldn't, right? And then like a light bulb moment went off for her that maybe, wait a second, I'm strongly biased. What do you think about this? Do you think that there's like a strong bias against, I think there's a strong bias against, quote unquote restrictive approaches, intermittent fasting, low carb. They're viewed as like incompatible.
Well, the thing is that if we ask ourselves the question of what is carbohydrate, cut out all the processed food, then and you what is compatible with human biology that we've been eating for millennia, that would look like a low carbohydrate diet, regardless of what you call it. Are you going to be metabolically flexible? Are you going to be ketotic at times? And are you going to have times where you're not going to be readily accessing food? Then yes, that's just normal state of affairs, isn't it?
Yeah. And look, I mean, exactly. If you take an evolutionary approach, but then if the modern dietetics and modern medicine is born out in the past 150 years, and it's like they've forgotten all of this. Brian, what do you think about this? I mean, I know you've experienced some of the same things as me.
Yeah.
Where they come at you for being too restrictive or low carb or, but then we know that carbohydrate restriction and ketosis has such vast implications on neuro and psychiatric health. So I don't like.
Well, I think that's the struggle, Troy. I think people are looking at it from a perspective of saying, okay, if you tell someone, look, you can't see this kind of movie or you can't eat this kind of food, that's all they're going to think about, right? They're going to just be obsessed with that kind of food. So I think that's the problem when you step back. Like I have some patients, I'll say, hey, what are you doing for Thanksgiving? And they go, well, I'm not having anything sweet, because once I have any sweet, whether it's artificial sweeteners, whatever it is, even without sugar, my mind goes there and I can't stop. I go crazy and I just can't stop. So when people start realizing that and say, okay, just like what you're saying with the alcoholic, of knowing which patient you are, I tell people, do you know yourself? If you can have one cookie and you're good for a month, okay. But if you have one cookie, then you eat everything that's sweet for the next 2 months, then you're a total disaster. So I think that's the problem, is realizing some people, you have to be very restrictive. Like one of my patients, she says, I am addicted to chocolate. That is my happy place. When my husband's mean to me, I go to chocolate. So now 10 days in, she's had 0 chocolate and she's very proud of herself. She has peanut butter, she has some other stuff, but she's not eating chocolate. Right. So I think sometimes when you start realizing, okay, let's take it a step at a time and see what we can do. And then other people, and it's the same for Ali, it's the same thing. The biggest fear we have in type 1 diabetics is hypoglycemia. So now you're fasting and running and doing all this stuff. I mean, people are worried about the low sugars. It's not happening physiologically. So sometimes you have to understand our physiology is going to provide that sugar that we need, right? So you don't have to be putting it in your mouth necessarily. So I think it's just a mindset of not having experience of seeing what happens, because I know what happens on a CGM. I know you didn't drop your CGM, your glucose to 0, and had you have, your ketones would have supplied enough energy for you to use, right? That's why when you're exercising, your ketones are dropping a lot of times. So, I think when you start understanding, okay, the body's smarter than we give it credit for, and that we can intervene and make some positive impact. And if those ketones help your stress level and you're a stress eater, guess what? You don't stress eat as much. And that's what we're seeing clinically.
What say you, Ali?
I mean, I couldn't agree more with what you say. I think that the thing that makes me very uncomfortable with the current food environment is that it's almost now the mentality is shift into considering, foods like, you referenced chocolates. It's now considered just part of normal human diet. People opt out of it because it's causing some problem or other, and one of those problems might be one feeling addicted to that particular so-called food, but the reality is that the ramifications, metabolically, psychiatrically, in whatever way, it's going to impact everybody. And the reality is that I think whether we like it or not, everybody is affected at along that spectrum in one way or another. It's just how are you affected? So while some people might get psychiatric illness, other people might be reporting addictions, others will have pre-diabetes and, metabolic syndrome and fatty liver disease and so on. So, and that's not to say that, I guess it's better thought of as a unified kind of, pathophysiology that's kind of part of a unified cause that's causing downstream manifestations in different ways for different people based on vulnerabilities.
That was the beautiful part of your paper with Dr. Ayton, the Western diet, the blind spot. I mean, that infographic that you guys put showing how basically modern food feeds into disordered eating, which then feeds into 2 ways of dealing with it, restricting, right? And getting ketosis, right? And then liking that feeling so much, you increase stress hormones, you restrict too much, you become nutritionally deficient, and then you have to eat again, and you're back in this cycle of anorexia. And then on the other side with the binge eating and the food addiction, how they would go into purging as a way of dealing with this modern processed food. And, the health ramifications that come with that, maybe weight gain, and then wanting to purge again. Right. So I thought that one infographic, and maybe we'll bring it up in a bit, was like mind blowing. When I read this, I'm like, these people get it. They get it. They understand, and
well, I mean, the reality is that, the whole of that narrative review was based on the fact, and that's why we called it the blind spot. I mean, there was a little bit of kind of, push and pull with me and Agnes, obviously wanting to be a little bit more kind of, less provocative, and me wanting to name it the way it is. And I think it's a genuine blind spot, because the way that paper came about is us looking at what's happening elsewhere in all other specialties. And I think I'm pleased to say that in other kind of specialties in medical practice, we've picked up on, the modern diet and lifestyle factors and how that's affecting different disease conditions. And we're way behind the curve in psychiatry in general, but in eating disorders specifically. And I think there's something interesting about how we've become, so on the one hand, it's quite advantageous to become, siloed in a way that gives you a specific insight into one area. That means that you get an in-depth understanding of that one area. But then if you become so blinkered in becoming so kind of, subspecialized and siloed that you're not able to draw on the parallel relationships to how it might be related to other things, then that's kind of where we're at, I think, in medical science, where we're forgetting those parallel relationships. And that's, I think, one of the biggest problems in the eating disorder field. So really the paper was kind of, it's grossly, it might not be immediately apparent to the reader, but it's divided into kind of two bits grossly, where the first part is, drawing that knowledge and drawing that knowledge from different specialties and making those parallels and how it might be relevant to eating disorders. And then the second part, making some suggestions as to how that might be relevant when you superimpose that to what is in existence at the moment in terms of eating disorder treatments, because most of that is psychology to the exclusion of anything remotely biological or dietetic. And the moment that you do that, you kind of make the best of both worlds. But I guess that can be easily misunderstood as well. The psychology is not important, and and people have turned around and said that to you're dismissing the psychology, Ali. And it's like, well, no, the psychology is really important, but you can't talk somebody out of an eating disorder. You can support them through it. And there's a lot of people that have landed themselves into an eating disorder with a background of trauma, with, there's a lot of psychiatric overlay, and you do definitely need that psychiatric support. But you see, unless we include all that knowledge that we've arrived at after so much harm that's been caused, if it's ignored, then in my head, it doesn't make sense not to extend the same kind of courtesy of offering the same options that are available to patients that are suffering from other conditions like diabetes, and offering those options to patients with eating disorders. Why would that be an immediate exclusion? And the argument goes is that, well, it's because if you start talking to them about dietetic factors, then you're exacerbating the eating disorder because you get them more fixated on it. Well, the issue is that was the problem in the first place. It's the food environment that shifted so much, that's made people so fixated on counting calories. All the guidelines promote.
Thin idealization, I think, is a huge factor too, right? The thin idealization, I think, is the real enemy here. Is that this culture of we're giving people addictive foods, and then we're telling them you should be ashamed of yourself for being fat and having an appetite, and you should be thin and you should be healthy, right? I think it's like the ultimate scenario to create an eating disorder. So you give them addictive food, like unhealthy food that literally rots your teeth, brain, etc., causes diabetes, right? Exacerbates glycemia. And then you tell them you have to be thin and you should be ashamed of yourself for being fat, right? And now in a world with social media, this is disaster. I fear for my daughter who's 6 years old. I fear for my son who's 8 years old. I fear for them, right? Because this is the world they're growing up in, and it normalizes this food,
You should be fearful, but the problem is that we now kind of, the environment at the moment is that, parents aren't actually aware of the full extremities and the kind of ramifications of what's going on at the moment. And I'm seeing, clinically, the extreme end of it, where, with the severity of the cases that I'm seeing in eating disorders, there are some, this week, it's frightening, Troy O'Brien, we're seeing cases that, I'm looking at these kids and I'm thinking they're nearing death, with anorexia, for example, or they're so disordered. And, it's frightening, and I think the reason why parents sometimes, it's not because they're not well intentioned or they're negligent of their children. I think it's more the problem that they're unaware of the problem themselves as parents and as adults, and so they can't really pass on that learning, or that at least they're not aware of the full extent of the problem. And the reality is that when you have both healthcare professionals and parents and families relying on, for example, what's promoted by guidelines of the government, then you take it in good faith, and you think, well, that's what should be done. But when the cause, when those are kind of based on what's what's been kind of pushed by industry, then you think, well, who's calling the shots here? It's a bit like you have a salesman at your front door who's trying to break through, and you let your kid go and open the door and let them in and have a good chat with them, and you leave them, and you don't. We wouldn't do that. So why is it that we're allowing the food industry to call the shots with what our children get fed and how much they get fed and how many snacks and calorie content and and all the messaging on all the packages? It just doesn't make sense.
But this goes all the way up the food chain. So like you're talking about the guidelines, that's one thing, right? But then if you look at how they recently treated, Dr. Unwin, where they retracted his, spoons analogy, and then literally the next month and put, all the orchestrators of that put a piece together with CGMs, like a hit piece, basically. I think it was on the Daily Mail or, one of those things, or, and then literally a month later, those same people that kind of conspired to get this infographic kind of, to smear this infographic, they announced an NHS, basically soups and shakes sponsored program. And I was just appalled. It was like, it was like a beautiful symphony, I would say, really, but it's certainly diabolical. Almost, I'd say.
I mean, it speaks to how we've gone as a society. Somebody's trying to do good work to educate people about, what's happening, and we get an attack of that extremity. It's beyond.
Which was coincidentally 2 months before this, NHS program of soups and shakes that they're trying to put out for diabetes. It was just terrible. My heart broke. But I want to come back to something, and Brian, I want to get your take. The main thing about when I looked into the literature for eating disorder prevention, where they go to the super high risk, young. Well, now it's really young men and women, but when these studies were done, they went to young women, and like Body Project and Dissonance Program and Healthy Weight, I think, is the most. The Healthy Weight program, which is the most popular, I think, in terms of the data that they have for eating disorder prevention. If you look at their nutritional guidance, they recommend restricting, right? They literally say, one of the key points is, they try to work on the thin idealization. They try to work on this fat shaming culture. Health at any weight. They try to work on these kind of supportive messaging, but if you look at their nutrition, it's completely disastrous. But if you do look, they say choose a healthy snack instead of a processed food snack, right? So they are actually saying like limit processed food, but then the same people out of the same breath, when they promote these non-restrictive diets, and they point to these eating disorder prevention programs. If you look at the eating, disorder prevention programs, they do to some element, focus on healthy eating, this concept of healthy eating. So I think that there's a little bit of hypocrisy, there. And I feel like last thing I'm going to say is, Ali, I feel like your relationship with Dr. Agnes Ayton is like exactly like my relationship with Brian. Brian's like the older, smarter, calmer voice, and like we're like the,
yeah.
the little bit more cavalier. So I don't know, Brian, what do you think about? Do you have any experience with this kind of criticisms from nutritionists and dietitians? Like, You know,
Well,
what's your take? You know,
the way you have to look at it, this is the reality we're facing. Like you have to look, I mean, there was just a video on, I don't know if you saw that video, but they were showing the inner workings of all these, how it works. Like, you know, the big food, the big pharma, they're each happy for the other one because the other one makes their product sell more, right? Because if you look at the mindset we're in, like there's a drug now that will decrease cardiovascular risk, help with heart failure by making you pee out more sugar. Okay, cool. So I go, how about if I just don't put the sugar in the system at the first place? And they go, well, that's nice, doctor, but no patient's going to stick to a low carb diet. I was like, really? Why not? Right. So when you say, can I spend 500, 600 bucks a month on a drug, or would I rather change my lifestyle? I'd rather use that money for something else if I'm the patient. So I think we get into these things where who's doing the education? You have to look at where the money all flows from, right? So for us as docs, Tro, you know, as well as I do, is that you put someone on insulin because they have high sugar, right? You put them on insulin, now they gain weight. And then you look at the patient and say, what's wrong with you? You're gaining weight. Well, because you're giving me insulin, doctor. So I think it's these things we just don't, you're looking at the wrong end game, right? The problem is this insulin resistance or hyperinsulinemia, and we give more insulin for the problem. And then we stimulate their hunger more, and then they get into worse shape. And then we realize when we get that insulin under control, you don't need as much of insulin as once you make their body sensitive. So I think it's one of these things where we have a mindset, this paradigm in medicine we just can't get out of, right? And then you have the social pressure, like Ali's saying, like when they say you got to be thin or you can't fit in, you're weak, and you have you're not a you have no willpower. That's your problem. So that's why the nutritionist you see says, well, I can just cut my portion in half. That's like I say, I can have a glass of wine and be fine. My alcoholic friend cannot do that, right? So it's one of those things where you say, just because you don't have a problem with a particular issue, you can't generalize that to everyone. And so we see the extremes. Like in our practice, that's what we're seeing. So it's a hard thing because I understand because people are trained that way. But the problem is at some point you have to look at your clinical outcomes and see how your patients are doing. If none of your patients are benefiting from your treatment, then you have to change your treatment. And people aren't willing to do that at this point because they think fantastically at some point the patient's finally going to get it and be able to do what they're telling them to do and do this liquid diet, which is restrictive in itself, right? You're doing liquid processed food diet. And so I've never seen someone have long-term success doing that. Never, not once in my career have I seen someone go on a liquid diet and sustain weight loss for 10 years.
you know, I remember
Brian Wiley. I've seen other people that have done it this way sustain it.
You know, Brian,
Yeah.
I remember we used to show pictures of anorexia patients on a ward with feeding tubes. You know, that's restrictive. That's restrictive if you ask me. If we don't understand the root cause and we don't treat patients properly, we are doing them a disservice. You know, we're doing them a disservice. I don't mean to, Ali, to trigger you here, but we're angry. You know, and we're angry. Like this is what we deal with on a regular basis, from diabetes treatment to, food addiction patients to, people who've suffered previously from bulimia and anorexia. I mean, and you're looking at one, at the age of 13, I didn't eat for about 5 weeks, nothing. I ate nothing, zero. I was anorexic, and you know what drove me? I remember the day that I was like, I'm never going to eat again. I remember the day I had just turned, I think 12 or 13. And I went to the doctor's office and I weighed the current weight that I am now. And I was like, this is impossible. I'm never going to eat again. The doctor said to me, you have to lose weight. I was so ashamed, so embarrassed.
But that's the problem, you see, Tro. You were told to lose weight, but you weren't told how to, or what the problem was, or how you got there.
Yeah, you know what I did? For 6 weeks, I didn't eat. And then for the 6 weeks after that, I had Diet Coke and lettuce. And then for the ensuing 2 years, I was vegan.
And you see, the thing is that is an example of many people that are experiencing similar things, and that's exactly how we're causing harm as a medical profession. I mean, that can't have been easy for you at the time. And I think for you, what makes you probably angry is thinking back to that, childhood version of Tro. And, if you'd had somebody telling you something different, it might have, that journey might have been different. But I guess, there are some blessings along the way of you picking that up and then wanting to make a difference for other people, and you're benefiting millions of other people in the process of what you've learned because of harm that's been caused. But I think that, you know, that's exactly the problem. It's the messaging that we're giving. It's the lack of knowledge. And it's interesting that you raised the question earlier about preventative care, because I think that's exactly what needs to be done. Because at the moment, what we're seeing in terms of you know, disordered eating and eating disorders, the kind of the milder end of the spectrum, I think, you know, so one can argue that everybody in the population is somewhere along the spectrum of disordered eating if we're surrounded by, you know, ultra-processed food everywhere. It's how it affects you, and so if everybody is somewhere along that spectrum, then, you know, there are those that are more affected by it, and then there are those that have, you know, further health ramifications as a result of it. But if in preventative care, that's what must be done. It's not, you know, it doesn't fall onto the medical profession to, you know, change just within medicine how we're operating. It's an entire societal responsibility. It falls on policy making and, you know, schools and families, and, you know, we need to work from the bottom up. But it does require massive policy change, and I don't think any of what's being said is anything that's kind of you know, maverick or new, or, you know, it's something that's already been identified, and, you know, the World Health Organization says it's an ever increasing, you know, problem. The ever increasing production and consumption of, you know, products of ultra processed food is a world crisis, is how it's referred to. So, you know, it's not anything that we haven't picked up, I guess, as a society. It's something that we need to act upon, and the issue is that we're not taking enough action. And my kind of main problem is it's been a very long time. You know, it's not as though eating disorders have been a problem recently. It's not as though the kind of end results of disordered eating or being exposed to a different kind of food environment is a recent thing that people are picking up. It's been there for a very long time, and you know, problem is that action hasn't been taken. I think there's individualized action. I think you guys are doing, for example, brilliant work. Other people are doing, you know, fantastic work, but it needs much more than that. And the longer it's left, the worse it gets. And I think with this recent pandemic, as we emerge out of it, we're probably going to emerge into an epidemic of mental health. And when we're talking about eating disorders specifically, I think it's going to put the magnifying glass on a problem that was there anyway.
Yeah, absolutely. You know, and you know, here's the thing. Let's. I'm going to come back to my own example. You know, here I am, age 13, 14, right? And my first experience with ketosis is basically being anorexic. My first experience of ketosis in my life, because I had gained weight up until that point pretty consistently, you know, with no reprieve on a high carb diet. My first experience with ketosis was at age 13. And I remember I remember, you know, like 6 weeks in, you know, my parents were concerned, my family was concerned. They're like, you have to eat something. So I was like, fine, I'll eat vegetables, just to placate them, right? And I drank Diet Coke, you know, because the vegetables actually made me more hungry. Eating made me more hungry. So I wanted to bloat up my stomach to not be hungry. But I remember feeling like I will never give this up. I'll never give this up. Like, it feels too good to be in control and not be hungry. And anyway, that was my first experience. And, you know, then processed food comes back in, people convince you you're unhealthy. And then I was unhealthy. I felt miserable. You know, I felt miserable after some time. I lost a lot of weight. You know, it was great. That social reward was excellent, you know, because we're thin, idealizing culture, right? But I really was becoming unhealthy. And
but it's interesting that you said you felt miserable, didn't you?
Oh, I felt terrible. Of course I felt terrible, you know. And eventually what's that?
But I said you were in ketosis.
Yeah, but so they made me eat. right? Everybody was making me eat, right? I remember 4 weeks in sitting at a family gathering, and I remember this. So, why aren't you going to eat? I was like, I don't want to, and I feel great. But then, the Diet Coke and the lettuce and the carrots, crept in, and then, eventually felt, certainly you get that reward, that social reward from losing weight, but then my body just, did not feel good. Did not feel good.
It's interesting that you say all of that, because and it must have been really hard for you, and obviously you remember it so vividly and you talk about it so eloquently, that these things do affect you, and especially when they happen at that age. 13 is something that kind of impacts you in a different way, because it gets consolidated in your memory, and it informs your kind of experience going forward. And I think it probably speaks to the good work that you're doing at the moment, how important it is to you, and it's heartfelt. But you see, the thing that, which is why I interrupted you, is that you now know, with the knowledge that you have, that at the time you must have been in ketosis, but you describe feeling miserable, and that this is what I see day in and day out with children going through exactly the same experience that you describe, restricting their food intake, feeling miserable, but yet feeling in control and clear, and their anxiety is or under attack, but actually more agitated and and miserable, but yet the anxiety is somewhat under control. Problem is, as soon as they have a little bit to eat, these children turn around and say, well, doctor, this is what's happening. I'm feeling worse when I'm eating, and it becomes a downward spiral of, well, I need to not eat in order to maintain relative degree of normality and capping my mental health issues. And nobody ever turns around to them and says, well, actually, there's a better way of doing this. Why don't we maintain ketosis by giving you a high-fat, low-carb diet? That way, you can control your mental health symptoms. You can maintain a healthy weight. You're never going to be overweight. You're never going to be underweight or unhealthy, and you won't be miserable. But nobody turns around and says that to the child. And the moment that you say that, you kind of get criticized for it.
I've been criticized for it. I've been criticized for that. I've proposed, I've asked, hey, these people that are ketotic and enjoy that feeling, why not try and introduce foods, that promote ketosis without the stress of nutritional deficiency?
Right, exactly, right? Exactly.
Which is what I went through, which is why I think I felt bad.
Exactly. Yeah. You've hit the nail on the head there. The kind of recent experience that I had, I think, for me, personifies this, what we're talking about, which is, me listening to all these children in clinic telling me about, how they're feeling the way that we've described, and then me going through the 0-5-100. And at the time, I think I felt in some ways what they described, as in I was feeling, I was high as a kite, I really was. But it was different. I wasn't edgy, I wasn't agitated. I was clear in my head. I was feeling calm, but energetic, and that's different. It's a different quality of
like a hibernating bear.
Sorry?
Like a hibernating bear, right?
Well,
or like a hibernating squirrel, or whatever.
Yeah, but there's something interesting about that, and I can't say that I understand, completely the underlying kind of physiology of what it is, to be starved and ketotic, because you're presumably still ketotic, but you're malnourished. Is the only way that I can understand it. I was obviously I wasn't starved. I was nourished, and I was in deep ketosis, and I had bags of energy, and I think that really tells me. And yes, it was a short experiment; it's a little bit different, but you see, the thing is that these things haven't ever been explored in a way that I guess most people will turn around and say, well, Ali, this needs to be done in a controlled trial, and you need to show results before you're able to advocate it. But what are we advocating at the moment? What's the current treatment? It's giving a standardized meal plan that's heavily ultra processed. Have we demonstrated safety of that?
No.
So am I medically safe, as a consultant working in a service, promoting that we give ultra processed foods to children versus giving them high fat, low carb diets that are natural foods? And the studies haven't been done, and because the studies haven't been done, we should revert back to the kind of normal state of affairs, which is eating normal foods, not factory manufactured food.
Man, I feel like you're my brother from, across the pond here. I can't, but sadly, I agree with you. We need controlled trials. We need controlled trials, but who's going to do that trial? Who would do that? And I don't know that it would be approved. I want to take, patients suffering, like let's say you were going to an IRB. Would they even approve that? I don't think so.
Yeah, but where are the trials to prove that it's safe to have, high carbohydrate, ultra processed foods? We haven't had any trials to prove the safety of what we're feeding children and adults at the moment. So, yes, I agree that we do need to have trials to this, to move things forward, to get people to pay attention. But I think we're understanding the whole kind of premise of, how we understand nutritional research, in a very obscure way, as far as I'm concerned, because we've landed ourselves in a position where we're consuming, products which we're referencing as food because the food industry is for their food, but they're not, for all intents and purposes, unrecognizable foods. But yet we're having to, produce the evidence to say that they're unsafe. Where was the safety data?
Yeah.
I haven't seen any. I mean, at least, not that I'm in favor of the pharmaceutical industry, but at least the pharmaceutical industry, they're extended the courtesy of, having an information leaflet on there saying, well, there are these, side effects, there are these risks, there are these issues, which, when you're having things in, kind of milligrams and micrograms in quantity, and, when it's being prescribed, yet we're having these foods day in and day out several times a day. There's no safety data.
Yeah, and there's a lot of. Hey, Tro, do you want to grab some questions from the audience while we're?
Yeah. I mean, we'll get to it. But what did you think about the lack of safety data?
That, and there's also like right now, like I've never heard of this before. Now all of a sudden, my patients are saying, "Hey, I'm gonna get a knee replacement." Now they're telling me I have to drink this liquid diet for 3 days before surgery, and it's all ultra processed soybean oil and sugar, basically. Like, wow, why were they putting people on this kind of? I don't know if you've seen that yet, Tro. But it's kind of a new trend they're doing, and they're saying, well, this is, to be healthy for surgery, here's what you have to do. I was like, wow, that doesn't make any sense.
Yeah, it's pervasive, I think, in all medicine. Ali, I have a quick question. So now, okay, so you have these interests, you put out these studies, working very closely with Agnes Ayton, who we adore, we've had on here. Guys, if you haven't listened to that podcast, go listen to it. And then you do this experiment with a group of amazing people, and where you run basically 5 days fasted to kind of bring awareness to metabolic health, the use of ketones. You don't need Gatorade, you don't need power bars, you don't need this stuff. But here you are, and I'm going to play devil's advocate. You deal with people with restrictive eating. So this may put you in a tough spot. People may criticize you, and maybe they already have.
Yeah, they have. Yeah, of course they would. I mean, I'd expect them to. I mean, to be honest with you, I didn't go in there to be provocative. Quite the opposite. I went in there to support a very good cause of, there's an option that should be made available to people with diabetes, and let's test out the safety. And I'm more than happy to put myself, in kind of an experimental condition, so to speak, so that we can benefit lots of people. And I think that the data that's going to come out of that is going to be beneficial to a lot of people. I think the controversy that may result that may be a result of it, I was kind of taken aback by it when I first heard about it, because, I was kind of with these guys, towards the end of this event, and they, I'm not on Twitter or social media, but they were getting a little bit of a backlash and some comments about what we were doing. And I was a little bit taken aback by that, because I thought, well, actually it's kind of the opposite. We're doing some really good work here to talk to people about it, which I have to emphasize is I didn't go in there to say, well, this is something that we can promote for eating disorders, or it should be promoted for eating disorders. It's but it does show something, and I guess what it shows is that these are all people that are able to do something like that because they're nourished, they're having a high fat, low carb diet, and they're able to embark on experimentation like that. So I guess it speaks for how important nourishment and good nourishment is, rather than anything else. Now, I guess, you know, and I appreciate you saying you're playing devil's advocate, and I think that's important. And I think, yes, absolutely. Can it, you know, the question is, can it be triggering for people that are experiencing, you know, difficulties with eating disorders? And yes, absolutely. If you misinterpret the message, then yes, in the same way that there's lots of confusion that's been promoted by, you know, guidelines in the food industry and misinformation on food packaging, all of that is triggering for people with eating disorders. So what we're doing is trying to reverse some of that, I guess, or what the result of, you know, something like this, which can be, which I guess can be, you know, taken the wrong way, is actually kind of the opposite message. Now, obviously the caveat to all of that is that there's a difference between people that are at risk of eating disorders and the risk of, you know, an eating disorder being exacerbated or developing one, and the people that are, you know, deeply kind of experiencing a current eating disorder. So, for example, somebody who is currently hospitalized with anorexia nervosa, hearing anything that's remotely to do with restrictive eating is likely to affect them, it's going to impact them. Now, if obviously that is explained in a way that is framed in, you know, in the way it has to be, which is the reality of the situation, which is these guys are people that are having, you know, large amounts of fat every day, then, well, it's what, you know, that's a message that I think is useful for, you know, somebody in that situation who's being treated for severe anorexia nervosa. Also, you know what, let's get you on a high fat diet. You know, are you able to do that? And then, you know, if you know, for example, you're starting your day off with, you know, a couple of ribeye steaks, and you don't want to eat until, you know, later on in the day, then I don't think anybody's going to have a problem with that. But that's the inherent part of the problem, that, you know, you've become so kind of terrified by the current food environment that you're not, you know, you're not kind of eating anything. So if you were to sit down with people that are at higher risk and say, well, you know, let's have a high, which I think is actually a therapeutic approach, but I guess that's, you know, a different discussion. But if you were to sit down with them and challenge them with, you know, high fat, then most of them will turn that down. And I think it would kind of, you know, flick a switch in somebody who's experiencing an eating disorder in their head and saying, well, you know, that's a different way of framing it. It's not that they're fasted, it's that they're fat adapted.
Imagine why they would turn that down. Why a patient with anorexia would turn down the message of a high fat diet. It's because the dietetic industry has been, you know, shaming fat and saying fat has more calories per, and it's in the thin idealization that they've promoted. So they've set up the framework for, you know, these highly nutritious, high fat foods to be adopted. You know, they've set it up to fail. So look, Dr. Ali Ibrahim, I love your work. I love everything you're saying. I love your message right now. I'm going to open it up to some questions here from some people that have joined us, our Patreon supporters. We appreciate you. People from Brian's practice and my practice. We appreciate you. We hope you guys like this community feel. We have a couple questions here. What was your sugars looking like when you were sleeping, when you were running, you know, on the CGMs? What did it, you know, and did you lose any weight during your 100-mile fasted run?
Yeah, that's a really interesting question. I'm pleased that somebody asked that, because I did maintain kind of a blood sugar of just below 3. It was about 2.8 throughout. I don't think it varied too much at night. It would drop a little bit, come back up, but it was kind of pretty much a straight line. Like I said, it wasn't there for me personally. It wasn't there consistently because the technology kind of kept going in and out. For the others, I think they report similar kind of patterns, but it will write that all up. In terms of weight, that's a very interesting question.
And 2.8, guys, is like about 50 or 60 milligrams per deciliter, just so you guys know.
Oh, sorry about that.
Yeah, it's all right. Yeah, that's fine.
I mean, there were times where I kind of dropped to 2.5, and, you know, it was kind of in that range really, but it was consistently below 3. In terms of weight, I think it was variable across the 8 of us. People went, you know, had different degrees of change in their weight. The thing that was interesting for me, I'll let you take a guess, Brian, Sherry. What do you guys guess happened to me?
I'm gonna say.
Well,
Take
were
a
you
sec-
training? Well, my question would be, were you training a lot before this, before you actually did the fasting? No.
No,
No, I'm
normally
gonna say
I
then
do-
no weight gain. I'm gonna say no weight, maybe 2 pounds weight loss, nothing.
Yeah, I'd
You
say.
see, yeah, I mean, that's an interesting question, Brian, because I normally do exercise quite a bit, but obviously, you know, in preparation for this, we've been clinically really busy, and I've not had the time to be doing that much training. I didn't prepare at all for this event. You know, it's quite the opposite. So this is me kind of not doing as much as I normally do. In fact, I wasn't doing very much exercise before this event.
I'm gonna say 2
I'd say
pound
probably
weight loss.
4 pounds.
Yeah, you know what? I think I maintained my weight.
Wow.
Yeah.
Because I'd imagine the stress hormones would go up, right? Because he's not trained, right? And probably put on.
We tested all of that, not much. But the interesting thing is that I really wasn't drinking that much during the day. So during the runs.
Not even chipping on, not even drinking much water.
Yeah, no. So on some days, in fairness, I had a little bit because they were quite hot days.
Yeah.
But the majority of the days I pre-hydrated, post-hydrated, didn't drink throughout.
Yeah. Wow. All right, let's keep going here. We got a couple more questions and then we'll let you go. I know it's later there than it is for us here. Let's see, recommendations when you are in ketosis for a long time, via low carb and inclination to overeat and binge still present. So do you have any recommendations if you've been in ketosis for a long time, but I guess somebody's saying that they still have these, how do you approach overeating and binge eating, clinically? I guess maybe that's the way to frame the question.
Yeah, that's a really good question, because it's how do we approach binge eating disorder and bulimia as is recommended normally is something that maybe we shouldn't talk about, because I don't think anybody's going to be happy with it, and I might kind of get you upset all over again. But the way it should be managed and the way I would advocate for it to be managed is exactly that, by taking out the things that are causing the problem, which is almost always carbohydrates. And as you know, we did our recent survey, and all binge foods, 100% of binge foods are ultra processed. So taking them out is going to solve a big problem. Yes, of course, the psychological intervention is important. You see, the interesting thing is that what the person that's asking the question is describing is something that I've been asked several times over. So people are coming to me these days, and they're asking me, they've already started low carb, they've already started keto, for example. It's not a case of what shall we do for binge eating and bulimia. It's what is this okay, doctor? Is this okay that we can carry this on? Is what sometimes is happening. But frequently the question is well, I've been doing it for X amount of time and I'm still experiencing these compulsions, and some of them are actually still even not just feeling compelled to binge, but actually binging on real food. And I think that the problem is that when you're exposed to ultra processed foods and your appetite is so dysregulated and so broken, I think it's going to take some time until and I don't think we've fully understood the kind of ramifications of what's happening. And my contention is that it's to restore normal appetite is going to take some time, but also the psychological overlay is important, and where even though we might have addressed some of the dietetic aspects, we're still living in an environment where you're surrounded by temptations and messages, right, left, and center. So it is both things. Yes, it is the psychology, but it's also that I think it takes a little while for some people, especially people that have experienced, over binge eating, for appetite regulation to be to return to a relative state of normality.
Yeah, can I give some insight there? I think that I basically binge ate my whole life and was exposed to modern processed food my whole life. And I feel like you always have to up the ante. So it's like not just one bowl of cereal, it's 2 bowls of cereal, then 3 bowls of cereal, then you're eating the whole box to get the same hit so to speak. And what happens when you take that away? Well, anything that drives you to need that hit, the magnitude you need is really high, right? So whether it's stress, sleep deprivation, whatever it is, right, that drives that, or, you know, somebody pissed you off, your kids yelled at you, your wife yelled at you, your partner doesn't call you, you know, your podcast co-host doesn't give you calls back, you know, whatever is driving it, right?
Not getting involved.
Whatever drives it, right? You know, whatever drives it, that now you're used to, you know, and I think if you look at like people who overdose and die from overdoses, a lot of times it's people going back to heroin, for example, and they're giving, after not exposing themselves to heroin or opioids for a long time, something drives them and they need that hit, and they go back to the same dose they were doing before, and then they die, right? So I wonder if it's, you know, again, I think it's a multifactorial, but examining the stresses, the sleep, like these are our 5th, 6th, and 7th lever. Like you need a new way to address your mental health, whether it's regular exercise or activity, good relationships, bonding, church, temple, whatever it is, you know, an uplifting podcast like Life's Best Medicine, you know, whether it's something like that, right? But along with sleep and stress need to be addressed. These are triggers, you know, so hopefully that helps out. So we have a couple more questions. You basically lost no weight, and somebody re-asked that. Any opinions on using higher protein versus higher fat for weight loss versus mental health? Do you have any opinions on higher protein, higher fat, you know, for mental health reasons or for just weight loss?
Well, I mean, I guess the weight loss question is probably for you guys because you have a little bit more experience with that, although I would contend that eating disorders, it should encapsulate all of those presentations, you know, right away from, you know, it's a full spectrum, isn't it? And obesity should be part of eating disorder services. It is, you know, as far as, I'm happy to be kind of, you know, challenged on that one, but I do think, you know, obesity is part of the spectrum of an eating disorder. And it should be, we should be dealing with them in all the same way. I mean, I guess, you know, fat versus protein, I would say that you should, if all being, you know, the same, we should be having food as occurs in nature, is what I would say, rather than manipulating, you know, kind of macronutrients and unless there's a specific target therapeutically that you're chasing. So, for example, we know that high-fat diets, you know, control seizures, and we've known that for, you know, a good part of 100 years, and we're using it for children, and it's therapeutic. And if that's what you want, then fine. And it's interestingly, when I've tried it on myself, I guess where I've dropped kind of proportions of fat in my diet, and you can only really do that when you're, you know, actively doing that. I just wouldn't advocate for that. But if you do that, and from my experience of having done that, what I do feel is that it's mentally it's very different, and I think that's probably an experience that's shared amongst many. So people would probably say, well, you know, I might want to, I don't know, cut down a little bit of fat for a short period of time because I'm looking for a certain, I don't know, body fat percentage or weight loss for, you know, but I don't think it's, well, I don't think it's sustainable. I don't think I think the same kind of outcomes can be achieved over the longer term. And I think you're going to compromise something along the line. And for me, certainly dropping fat compromises, you know, both mental sharpness and mental health. But I mean, I don't know if you guys have probably got more experience than I do with this one.
No, I mean, no Paleolithic era human would have stopped their hunt to add cheese or butter, you know, to their kill. Like, you know, just don't die, carcass. I'm going to be churning the butter. I'm going to put it on here, and then I'm going to eat you, right? So, but they wouldn't necessarily avoid fat either. In fact, they would probably prize the fatty cuts of meat. So I think the way the human diet is now, you know, when you're used to adding cheese, butter, cream to increase the palatability of something versus accepting the fat that comes with the food. And then you run into the whole idea of, you know, how we're grain finishing cows to make them fattier and how we're fattening up chickens. I mean, there's a lot of intricacy and nuance here, but I mostly, for the most part, I agree with you. I think we have one more question here. Repeated experiment, and then we'll call it repeats experiment with essential amino acids, muscle wasting during. Was there any muscle wasting during the experiment? I guess is the question, or how would you have known? You know, did you guys use bioimpedance scales or no? Did you guys do like those body fat scales or anything like that before and after?
No. I mean, there was a kind of a yeah, there was a different version of that. It was a little handheld one that was using. Yeah, I mean, so the question is about muscle wastage. I think
we could probably extrapolate. Any interesting data from the handheld body fat meter?
Yeah, it was this kind of it was a different one. It was one that I've not seen before. That, you know, just kind of like a portable one that's placed on an ankle, and yeah. I mean, I'm not sure that it really showed anything. I mean, I don't know how to quantify about the accuracy. But in terms of yeah, I mean, in terms of muscle, there wasn't any. Is the answer. But over 5 days, I mean, would I expect to be having any? I don't know.
Yeah, and ketones are muscle sparing too, so I would anticipate you didn't have much at all. Like, there's some data saying maybe you're going to break down more. Jason Fung's talked about this. You may have some more protein intake after 2 or 3 days of fasting, but a lot of times those, you know, there's the autophagy type thing where you're breaking down bad proteins, not necessarily muscle mass. So yeah, I wouldn't anticipate that, especially with the amount of exertion that you were doing. You know, you're probably just leaning out the muscle, the fat in the muscle, I would think. Because you had to run on a fuel source somewhere, and especially if your weight stayed neutral, which is kind of interesting over 5 days of fasting and working out to that extent.
Yeah, I think Brian, we got to do one here. You and me will run 100 miles.
Yeah, I'll do it, man.
Fast.
Might take me a month, but we'll do it, man.
Listen, when we open up the borders, Dr. Ali Ibrahim, we got to get you here, and you can make sure me and Brian fast and run for 5 days, 100 miles. Well, that's 20 miles a day. Holy shit, that's a lot of miles. I just thinking about it. 20 miles a day is still a lot, you know?
Yeah. Well, it was actually really good. It was, you know, we were going through some really picturesque landscape. It was actually really nice. It was, you know, I probably had the same thought in my head, you know, before we did it, that, you know, holy cow, how are we going to do that? That's, I really don't know how I'm going to do this. But actually, it was, if anything, it was really enjoyable. Probably one of the best experiences I've ever had, because, I mean, as I said, halfway through, and I don't know whether I can entirely explain it in terms of ketones, but something flicked in my head. You know, there was a switch that just went, and I felt it. I remember the moment. I remember where we were, and I looked over to the guys and I said, a switch just flicked in my head. I need to do something. I need to throw in some sprints here. So I started sprinting.
Was that 48 hours? Was that at 48 hours?
I wrote it down. It's in the blog that I wrote, but I think it was at about that. It was probably about that.
Yeah.
I think it was either day 2 or day 3, but, you know, we'd finished for the day, almost finished for the day. We're coming to the end of our 20 miles or whatever it was, and I was, you know, I was saying that, you know, just something suddenly smacked me in the head, and I felt, wow. And then so from that day onwards, it was this surreal experience where literally I started, you know, seeing colors in fluorescence. I started, you know, it's something that I've never experienced before. And the only kind of, I guess in my head, it's the closest that I'd probably get to, you know, using some kind of drug, and I've never dabbled into drugs, just in case you ask, but, you know, it's what I imagine it would feel like to use something. It was just, yeah.
We certainly hear that, you know, a lot of times with that 36 to 48 hour mark, with regards to whether it's high ketones or something else. Listen, Dr. Ali Ibrahim, Brian, it's always a pleasure. Dr. Ali, you have to come back again. We got to bring you back.
offer of running across the border.
All right, perfect.
Yeah, come on over.
When we do a low carb MD conference here, then we're gonna invite you to speak. So when they open up the borders and Corona settles down, hopefully that day will come soon. Brian, anything else you want to say? You want to do our closing?
No, Ali, thank you. No, thank you so much for joining us. Thanks for, sacrificing your body and doing this experiment, because I think it's really cool, really, and having the type 1s with you and just seeing physiologically how this is done. I think that it really does answer a lot of questions for people. And it probably raises a lot more questions also. So yeah, thanks for the great work you're doing and what Agnes is doing. It's remarkable. It's really important that we all kind of come together and use our expertise. So having you from the mental health aspect and eating disorders, it's such a huge problem. It's so complicated. There's no simple answer, I don't think, but you're going a long way to answer a lot of questions. I think, helping a lot of people. And maybe you can analyze Tro too next time you come on.
Oh yeah, I'm all sorts of messed up. Listen, how do people? I know you don't do social media, but let's say somebody wanted to reach out to you for an interview or something like that. Who knows? How would they find you?
Yeah, I'm happy for you to share emails. I'm really sorry that I haven't broken into Twitter and things like that yet. But there we are.
How do they get in? How do they get to your blog at least?
Oh, that's on the so everybody that did that 05100 event is on the website, so 05100, and I can give you the link to that, and people can go. And it's not just me; it's everybody that did it. And I guess we need to thank Ian Lake for having thought of the idea and for having facilitated it. And yeah, by all means, go there and have a look. Excuse some of the way that I've described some of the things on there. Literally, I didn't edit what I wrote on each individual day.
That's awesome. And is there a way? I know you prize your privacy, but if somebody wanted to reach you, is there a way you're comfortable sharing?
Oh yeah, no, absolutely. I have no problem in personal contact. So by all means, email me or anything like that. But yeah.
Okay, and we'll share your email in the notes.
No problem at all. Yeah.
All right, awesome. Thank you so much.
All right.
It's been an absolute delight.
Thank you. And hey, thanks to all the listeners for sticking with us and for asking questions. And we greatly appreciate your support. Tro, you want to close this, man?
No, that's it, guys. Until next time.